Greetings. So let's talk about the assessment of fluid status. So that's what we're going to focus on today in this lecture. So the first thing we want to do is what are we trying to assess? So remember we had three compartments. We had ECF, ICF, and the third space. Okay. The volume we are hoping to assess is ECF, not ICF and not third space. It is very difficult to assess, go inside the cell and see what the volume status is. Okay. Okay. So it's actually extracellular fluid status that we're assessing. So there's three possibilities, and I call it the Goldilocks: too much, too little, and just right. Too much is hypervolemia, ECF overload. Just right is euvolemia, and too little is hypovolemia or ECF deficit. Okay, so let's see assessment. So clinical assessment. If it's ECF deficit, what are things you're looking for? Okay, low skin turgor. You pinch the skin and there's actually tenting going on and it doesn't recoil back very quickly. That's decreased skin turgor. There's dry mucous membrane. Look at somebody's lips, okay, and tongue, and you're going to see it's not moist. And then sunken eyes. Okay, so these are three things you're going to see on the exam questions. When somebody is giving you this in an exam, they're trying to tell you what? The patient has ECF deficit or hypovolemia. Now, in real life, it's not very specific. You may have older patients who are well hydrated, but their skin turgor is still bad. And then, um, dry mucous membrane, they may be hypovolemic, but they may still have moist mucous membranes. Okay. So it's not very useful clinically. It's difficult sometimes with these assessments. So in real life, what shores up the diagnosis is actually some specific history. So history of low intake, so nursing home patient not eating, or history of increased loss, like fever. What happens with fever? Patient becomes metabolically more active and they start to have more loss through the skin. And then specific signs, which is blood pressure goes down, heart rate goes up. So attach that low BP, high heart rate, or high pulse to the specific history and orthostatic hypotension. So if you can do that on the patient, this is something to do clinically, which would shore up your diagnosis if you're still not sure whether the patient is hypovolemic or not, is orthostatic hypotension. Okay, so how do you do it? So again, exam question, if it gives you these three, it's telling you it's hypovolemia. Usually exam questions may or may not also give you a specific history, and if they give you some vital signs, they'll probably give you low blood pressure and high heart rate. And if they want to have you tease out stuff, they'll give you orthostatic hypotension and whether that's positive or not. And essentially, the test questions, if you see these together, they're clustering and giving you what? Clinical thinking. If this is in the room with this, is in the same room as this, they're giving you what? ECF deficit. In real life, these three are not as specific, but the specific history and specific signs, these two are specific for fluid volume deficit. Okay. Now, orthostatic hypotension, just real quick, how do you do it? 30, 20, 10. If you can remember that, you can remember orthostatic hypotension. Okay. How do you do it first? You have the patient supine, you take their blood pressure, heart rate. Have them sit on the side of the bed for a minute, dangle their legs, and get their blood pressure and heart rate. Third, let them stand. Have them stand for 3 minutes, and then take their blood pressure and heart rate. So you're going to get three numbers. Okay? You're going to get three numbers. If the patient has signs of syncope or near syncope, meaning they're going to say they're going to pass out, or they do pass out, regardless of whether they're sitting or standing, that is a positive test for orthostatic hypotension. Okay? That is a positive test for orthostatic hypotension. If when they sit or stand, their heart rate goes 30 above when they were supine, or the systolic goes down 20, and or the diastolic goes down 10 below the number when they were supine, that is a measure, that is a positive orthostatic hypotension. Essentially, if these are the drops in the vital signs, the increase of heart rate and the drop in BP and systolic and diastolic, that tells you they don't have enough fluid, which is why when the positions are changed, they have profound enough cardiovascular uh, numbers that you're getting to see, which may be contributing to insufficient blood going to the brain, which may cause them syncope or passing out. So if they have these vital signs, any of these, or they have symptoms of syncope, this is a positive orthostatic hypotension test. And if it does, guess what? They are ECF deficit. Okay. Now, AHRQ at this time, when we are making the videos, also talks about one may consider as soon as they stand up taking another measurement that would make it fourth measurement. Okay, that's not required, but it's helpful if the patient does have near syncope symptoms at the time they stand, because then you can actually take a look at what the numbers are, and that can give you a clue as to what the underlying etiology may be. Okay. What else can you check? Intake and output. So, especially in the hospital, you can check how much they've had past day or so, past 24 hours. And if their output is much higher than their intake for a few days, that may give you a clue that they are losing fluid. And then you can look at what they came in with, and if they came in euvolemic and they've lost a lot of fluid, then they are more likely to be in ECF deficit, right? Okay, so that's ECF. We've talked about exams and we've talked about real life and how to tease things out. Okay, now let's talk about ECF overload. Okay, so when somebody comes in and they have edema, that is a big flag for whether they have too much fluid on board. Okay, so um, if they have edema, which is not pitting, what does that mean? So remember, from anatomy and physiology, non-pitting edema is exudate edema. There's inflammatory causes. So we look for other causes other than sodium and water and hydrostatic pressure and oncotic pressure. Okay, so that's the easy part. If the edema pits, so if they have edema, there's ECF overload. Okay, there's ECF overload. Okay, if the edema is not pitting, right off the bat, you can say this is an exudate kind of edema. Okay, if the edema is pitting, it is not an inflammatory cause. It's either hydrostatic or oncotic pressures where things are not really lining up, right? That's the edema. So that's going to be the pitting edema. Now, you may have when you have that edema, you know that their interstitium is, they have a lot of fluid in their interstitium. Okay, so that's actually something you can observe right off the bat. So that's overload in the ECF. Well, ECF also has the vascular space. So if they have increased jugular venous distension, what's that? So again, in textbooks, you're going to read 45 degrees and do this, and then take a ruler and da 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 da. The simple, so again, on the exam, stick with the ivory tower of nursing. In real life, have them sit up 90 degrees, have them turn their head to one side or another. Okay, you're going to see the sternocleidomastoid. So when they turn their head, you're going to see the sternocleidomastoid muscle, and you're going to see a little attachment coming out of it, and there's going to be a little triangle. If you see any blood vessels pooching out there at any height, that is a positive JVD, jugular vein that is distended. That tells you there's a lot of fluid in the vascular space. So again, with ECF, you can have a lot of fluid in the vascular space, increased JDV, increased JVD. You can have increased fluid in the interstitium, which is dependent pitting edema, or you may have non-pitting edema, which is an exudate kind of edema and not a transudate kind of edema. Okay, so that's sort of uh, some of the specific edemas. There's a couple of other things which one can do, which is increased weight. So if when a patient's weight is taken, that's the number one reason in the hospital for weight gain is actually increased sodium. So that's a very interesting concept. That's why we weigh our patients as much as we can. And then intake and output. If we see a patient came in, they were euvolemic and they have been gaining fluid past few days, a whole lot, um, that may give you an idea of whether they have excess fluid volume. Okay, so that gives you a bit of an idea about how to clinically assess things. I'll give you a very quick approach to edema, okay, when you're in a clinical setting. So remember K times H minus O. K is inflammation, so that would be non-pitting exudate, okay? It could be, it's mostly local, so infection, cancer, autoimmune, and trauma, okay? So that's mostly local. On your sick patients, if they have general inflammation of the body, it's usually sepsis and pancreatitis, okay? If it's not inflammatory and hydrostatic pressure is more, it's pitting, right? If oncotic pressure is less, it's also pitting. Both of those are transudate. So usually hydrostatic pressure is regional, CHF, cirrhosis, clots, venous insufficiency, okay? And there's more as well. But essentially, if you have a clot, how to think about it. If you have a clot, now the veins can't actually adequately bring that blood back to the heart. So there's a backup. And then there's a backup, there's increased hydrostatic pressure pushes that fluid out, and suddenly you see a patient with the clot in their legs having edema in that leg. That edema will be pitting. You got it. What if the edema is not pitting? Unilateral non-pitting edema. Now I gotta look for infection, cancer, autoimmune, trauma. Which is not pitting. It's an exudate. Gotcha. What about CHF? Hey, what's the issue? What's the issue? My heart doesn't pump, so I have backup of the blood. These veins are engorged with blood and they leak out. What about venous insufficiency? Man, these veins, their valves are not doing well. Again, hydrostatic force. Cirrhosis, well, wait. Cirrhosis, you have low protein. That is correct. However, you have what? You have a lot of blood volume, in the mesenteric artery that pushes this fluid into the peritoneum, and we call it ascites. Ascites. So cirrhosis actually causes increased hydrostatic pressure in the abdominal blood vessels, right? However, it causes decreased proteins everywhere else. Okay. And then you have nephrotic syndrome. What's one fun thing about nephrotic syndrome? You pee out all your proteins. So you have what? Anasarca, edema all over. Why? Shh. Edema all over. Why? The protein, there's no oncotic pressure to pull it back in. Okay? Excellent. So that's sort of our approach to um, edema. Let's quickly recap what we talked about in the video. We talked about what compartment are we assessing, possibility of too much, too little, just right. With ECF, what are some of the signs and symptoms? Which ones are you going to see on your exam? Which ones you're going to actually help you in real life? And how to do that, how to get that information. And then we talked about overload of ECF, where we talked about pitting and non-pitting edema, and then even within the space in the ECF, intravascular versus interstitium, how do you get more information regarding their fluid status? And then we did a quick approach where we talked about how non-pitting edema is mostly local, and then regional is mostly the hydrostatic pressure, which has gotten high. And then again, if it's all over the body, it's generally the oncotic pressure. And that is, and again, we talked about which ones would be exudate, which one would be pitting versus non-pitting.